Hi, everyone. Welcome back to the Breast Cancer Podcast. Hello, I'm your host, Dr. Deepa Halaharvi, a fellowship trained breast surgeon, and also happen to be a breast cancer survivor, thriver, and a warrior, living my best life. As you know, breast cancer affects millions worldwide, touching lives in a profound ways. Whether you're someone facing a diagnosis or a supporter seeking information or just eager to learn more, this podcast aims to be a beacon of understanding, hope, and empowerment. I'm here to talk about all things breast cancer, from surgery to survivorship, as well as high risk for breast cancer to metastatic breast cancer. My goal is to provide you with reliable information, share inspiring narratives, and foster a supportive community. I know firsthand the challenges breast cancer diagnosis brings. Throughout this podcast, I will give you strategies to handle difficulties that arise from cancer diagnosis. We'll have insightful conversations with medical experts, researchers, survivors, caregivers, and advocates. I will tackle topics that impact our lives as cancer survivors. My goal is to educate you and empower you to live your best life. I definitely have. Well, let's get started. I am so excited today. Welcome, everyone. I'm so excited today. We have Dr. Karishma Kirti. She's from Mumbai, India. And I just cannot believe we are actually looking at each other. And you're beautiful, as seen you in the videos. And I've been very impressed with what you do for the social media and for your patients. And so I want to welcome you. And I'm here with myself, Deepa Halaharvi. This is Dr. Pankaj Tiwari. And we have our own podcast. Mine is called the Breast Cancer Podcast. And yours is
the best podcast ever.
Yes. And so we've been collaborating and doing a lot of podcasts and videos together for education of our community. So we are super excited. We do take care of quite a few Indian Americans in the United States. And so we wanted to talk to you today. And I just, for our audience, if you could just introduce yourself, that would be great.
Hi everyone, I'm Dr. Karishma Kirti. As Dr. Deepa said, I am a breast cancer surgeon working in Mumbai, India, and I'm very, very excited to be here. Other than my normal everyday work of being a breast cancer surgeon, I really enjoy and it is my passion project to bring more awareness about breast cancer in India because that is the need of the hour. So I think we both, come together on this passion project of ours, and through our schedules and our time differences, I'm really, really glad that the three of us are here today to talk about our favorite thing.
Yes, that is correct. Yes. Welcome. And so I wanted to start out. I was looking at some statistics of breast cancer in India. In the United States, we say it's well over 300,000 men and women gets diagnosed with breast cancer every year. And some of the statistics I was looking at, there was a number that said there's a 62% increase by 2040. So what are the statistics in India right now as it stands?
Right. So in India, breast cancer is the most common cancer in women. It used to be a cervical cancer, but I think with urbanization and improvement in the general socioeconomic status in GDP, we are moving towards an urbanization, better healthcare, but that also has sort of increased the risk of breast cancer as well. In the US, I think you have a 1 in 8.
Yes.
You say lifetime risk of developing breast cancer. In India, there is a huge rural urban divide. So while in the rural areas, it's 1 in 64 women are supposedly have the lifetime risk of developing breast cancer. That's hardly 1.5% lifetime risk. In the urban setup, it's 1 in 24. There is a huge difference between the incidence of breast cancer in rural India versus urban India. If we look at the causes and I think the risk factors, it's pretty evident why the divide, but we can discuss it more as we go into it. But yes, number one cancer, the mortality from breast cancer also comes, in India from breast cancer.
Yeah, those are very interesting statistics. Do you think that it's because of a true difference in the incidence or just a screening difference?
Overall, I would say that we don't have government funded or planned screening anywhere in India. Of course, over time, we do realize that everywhere in the world, we are diagnosing more. And of course, that also has put up the numbers of breast cancer because we are screening more and diagnosing more. But in India, overall, there is no screening. So patients come to us with symptoms. And I'm sure that a part of it can be because women in the urban setup are more likely to reach a doctor with earlier symptoms or reach a doctor at all. But I would say that that huge difference that is there, that cannot solely be because of just screening and access to healthcare that is present in urban India.
Yeah. So there are no screening recommendations, then, is what you're saying, correct?
Definitely, there are no screening recommendations, and we fall back a little bit on your guidelines, the USPSTF guidelines. But because there are no guidelines, it's every institute or every surgeon or every oncologist has their own idea of what screening should look like. So we do have some data that comes from India, and this was while I was at Tata Hospital, and we had a huge study that compared self breast examination to clinical breast examination by healthcare workers, not doctors, but nurses and other healthcare workers trained to do a clinical breast examination. And they found a big difference in the stage at which breast cancer was diagnosed and the mortality that came from the breast cancer that was diagnosed in the two groups, being awareness and self breast examination and clinical breast examination. So, with the kind of budget that we have, I'm not sure that we can sort of really go into a government funded
Mhm.
screening program and set up mammography units everywhere. I'm not sure we need to, but I think raising the awareness, and probably that's what we try to do. That when we talk to general physicians, when we talk to gynecologists, we tell them that you are the first point of contact and you need to make your women aware of what breast cancer looks like and do a quick clinical breast examination. Have a nurse, have a sister in your OPD who just does clinical breast examination and sensitizes the patient. Every female that walks into your OPD should have that.
That's such a great idea. We in the United States, there's so many conflicting guidelines on when one should start
Mm.
screening. And we follow the NCCN guidelines, the National Cancer Comprehensive Network guidelines, which recommend women starting mammography at age 40. Now, this is for women who are average risk, meaning they don't have strong family history of breast cancer. They're not considered at high risk for breast cancer. But we recommend just getting familiar with your breast, like around age 25 or so, and performing a monthly breast exam a week after, periods. If you're premenopausal, a same time every month if you're postmenopausal. And if someone is high risk, of course, they're going to start their mammography 10 years earlier than the family member who was diagnosed with breast cancer. And we say mammography really decreases mortality by like 30 to 50%. So that's our numbers here. But I will say, we are diagnosing more and more younger women. I'm sure you're seeing that, where the guidelines are not recommending doing a mammography. Really, I at least get 2 or 3 women every week that come in because they felt a breast mass and not because of a mammography. And so that's really good that you're emphasizing the clinical breast exam.
Now,
Yes, and
I'm
sorry,
sorry.
go
Go
ahead.
ahead. One thing I would assume is that your patients would be higher stage than the patients we're seeing here. Is that true?
So, probably. So, one of the things that I would like to pick up from Dr. Deepa first is that one is that the median age of diagnosis, right? In India, it's around 46 to 48.
Hmm.
So, when we talked about the screening guidelines earlier, even up to 2 or 3 years ago, it said 50 to 74 or 50 and above. And that kind of screening guidelines did not really pick up much in India at all. So, I think now that it's come down to 40 and above, I truly believe that that is something that recommend to my patients. And I work in a metro, so I do have patients with slightly higher risk factors, like when you talk about age at first childbirth, or even menopausal obesity and things like that, alcohol exposure. So I do have patients with some of these known risk factors. So I say, these are the risk factors. If you have even one, I think you should go ahead and start your screening at the age 40. Because there is, and also I think with every breast cancer patient diagnosed, do you do BRCA Pro for all your patients with
Yeah.
breast cancer?
So what you mean like BRCA testing, genetic testing, or are you
No,
talking
the
about the high risk
BRCA
screening?
Pro.
Yeah.
The BRCA Pro test to see what is
To
the risk
see.
there.
Yes. So here
Yeah,
we use the Gale model. We also use the titer Cusick. Some of
right.
our genetic counselors do use BRCA Pro, but the most common thing I see that we use is titer Cusick, which not
Right.
only looks at first and second degree relatives, but grandparents as well. So, and also his family history of ovarian cancer as well as breast density. So it looks at a lot more factors. So that
Mhm.
seems to be the most common thing that we use here
Yeah.
for
Well, the other
calculating high
thing is
risk.
that none of it is actually validated on our population.
Oh yeah.
So for us, it's just clinical, what we have seen, or what we think should be the way forward, and kind of personalizing the screening according to the risk factors that are known.
Okay.
Yeah. So the other thing I would say is that if you're talking about higher stage, and we have seen that even early on in practice, even 10 years ago, we were seeing patients came with higher stage diseases. And there was absolutely, I mean, I think maybe two patients a month who would come with something that was screen detected. But now I find a lot more women are aware of breast cancer, its risk, and a lot more, we have these health checkup programs
Mhm.
from the companies, from hospitals, that offer a package to women. And a lot of them are doing a mammogram through that. So we do see more screen detected lesions now, and maybe the stage is going, we are seeing slightly earlier stages, but still very, very few screen detected. And I would say that I see a lot of stage 2 ish. you know
Yeah, yeah.
Not many patients would come with even our DCIS patient screen detected, very, very few.
It'd be very interesting to see the next 100 patients that you see and that we
Mm.
see, and just take those 100 patients and compare them,
Yeah.
demographics, stage of presentation, self breast exam, diagnosis, and just see the differences. I think no
Mhm.
one's ever done a study like that that I know of, and it'd be an easy
Yeah.
thing to look at.
So, in America, we say around, 62, 63 is an average age for the Caucasian women, for when they develop breast cancer. For the African Americans, it's like late 50s. And I'm actually seeing more Indian people getting diagnosed in much younger stages. And I somehow have a lot of population that's under 50. So I diagnose my youngest patient is actually 19 years old. And so I have lots of young people. And most recently, there's a paper that came out in JAMA that talks about increased incidence of breast cancer in younger women for the very similar risk factors that you talked about is, nulliparity, not having kids or having kids late, or obesity, alcohol use, and then, of course, family history. And not just being aware of the family history. In America, a lot of the cultures, we don't talk about family history. I mean, I myself, when I was diagnosed with breast cancer, my mom, the first question she asked me was, I was going on the national news, and she's like, "Are you going to tell everyone that you have breast cancer?" I'm like, "Yes, mom, I am. That's the whole point." And she's like, "Oh my gosh, then everyone will find out." And I'm like, "I didn't rob a bank. I just have breast cancer. I'll be okay." So it's a very cultural difference. Families don't talk about it. So I'm sure that's the same thing in India. Is that correct?
Some of it, yes. So some, but you do find that, I hear where you're coming from, because sometimes people don't know who has had cancer. They had something, they died. Whether it was
Oh
cancer or
yeah,
not, they don't know where a cancer, from where, the site of origin. They don't know that either. And sometimes the family are also very large and scattered. So even up to their, especially women when they're married, what's happening with their mother's sister, they may or may not know. So
yeah.
a little bit that of the cultural bit also comes in. But overall, Yes, I think a bit of it is there, but we have like a heterogeneous group of patients. Some of them know their history in and out, everybody, what treatment they've taken, whether they were on hormones or not,
Mm.
everything. And some of them will have a very vague history that, yes, maybe she died, maybe she didn't, have cancer. I'm not sure. Some patients don't even know their own history. That is
Yeah.
different ball game altogether. That sometimes patients are treated for maybe tuberculosis, and they're not sure what they received treatment for, whether it was, I recently had a patient, um, I think she had some genital ulcers or sores for which she was treated, and she thought she had, cervical cancer, and that is the history that she gave me. And the next time, I think she came back with her daughter, and she was like, "No, that is not what she was treated for. She just had to take tablets, and it wasn't cancer." So, of course, as people get more aware, people get more
Yeah.
educated, and they would take more interest in their health also. And I find that doctors nowadays are also more willing to talk to patients about what you have, what this means, what are the treatments available to you, and what is your goal for treatment, what is my goal for treatment. So the whole shared patient doctor decision making is also coming in more.
Oh, wow. Yeah. That is so good to hear. Yeah. That is so good
Yeah,
to
that's
hear.
a big push for us, particularly in
Yeah.
plastic surgery, is shared decision making, and it's become something that we really try to focus on. Do you work with a plastic surgeon there regularly?
Yes, yes, I do. So, when we say oncoplastic surgery, I think we do level one, level two. So we would do rotation advancement flaps. We would do a few pedicle flaps, the AI cap and the LICAP flaps, and in some cases LD flaps, which is what we trained with a lot of latissimus dorsi flap. But now we're almost replacing it with more local flaps like the LICAPs. But when it comes to a whole breast reconstruction, especially when it comes to free flaps, we definitely have a plastic surgeon. And in fact, even when we have a therapeutic mammoplasty with a symmetrization, it's always good to have someone with a plastic background, and then you can do it simultaneously together. So yes, I have a very good, very trusted plastic surgeon in my team, and we work together all the time.
I had spent some some time in Ganga Memorial Hospital in Coimbatore. Incredible
Wow.
microsurgery, incredible.
Yes, yes.
And the head there, a gentleman named Raja Sabapati, had talked to me about how India probably follows the West by about 10 years. And I was there about 10 years ago. And we talked about how the changes in trauma with improved safety led to decreased traumatic reconstructions and an increase in oncologic reconstructions. And that trend definitely happened in the US. And I would imagine that that trend is kind of what you're seeing now in India.
Yes, yes, I would imagine so.
So do they perform deep flaps? Because that's something that Dr. Tiwari and his team, they perform those quite often here.
Yes, I think that's almost our first choice for whole breast reconstructions here, especially because few reasons I'll tell you. One is that we have that kind of body proportions, and that pannus in the lower abdomen is usually available, and we even use it when we do prophylactic mastectomies to
Mm.
reconstruct both breasts. A little bit of skin reduction with vice pattern and putting in that flap bilaterally. We do a lot of that. um, and the other thing is that some of our patients travel from tier two, tier three cities for their recons. So putting an implant, sending them back, not being sure of what kind of radiation they're going to receive, also makes it, it puts us at ease, putting a DF
Yeah.
flap, keeping them for those 10, 15 days, making sure that everything is, ship shape, and then sending them home knowing that even if the radiation is just a good quality average sort of radiation, that flap can take it. Whereas if you put an implant and send a patient home, you don't know if they're coming back, you don't know what radiation they're receiving. So compliance is also a bit of an issue,
Yeah.
but definitely DEP is our workhorse for whole
That's really
breast.
interesting to hear. I think
Yeah.
that's fascinating.
I'm
So do you know what percentage you do deep flap versus implant?
For me, in my practice, I would say it's almost 90-10, or maybe
Wow.
80-10. Yeah,
Wow.
so if we have like a DCIS or something like that, in which we know that we're probably not going to radiate and things like that, we save it for very few patients in my practice. But there are some doctors who are more comfortable with it, also because a lot of the oncoplastic surgeons will do an implant by themselves, whereas for the refab they will be, getting a plastic surgeon on board. So maybe that's also one of the reasons. But there are some doctors who use implant more often. The other thing is that we did not have acellular dermal matrix till on, just 2 years ago.
Uh-huh.
So putting an implant at that point meant either putting it subpectorally and lower, put a dermal sling, or to do a latissimus dorsi to cover it,
Mm,
which was then again fairly extensive. So because of that, I think DF has been something that we use in young patients who really don't have either the or really lean patients rather than young, who don't have that kind of volume in the lower abdomen. Maybe in them we would use very recently, actually we had a 23-year-old uh, with a phyllodes. I think we operated 3 weeks ago, and she had a phyllodes sitting there for almost 2 years, and because of COVID she didn't get treated. Then earlier in the year she also got pulmonary cox. So because of the tuberculosis, she was told that no, now you go have your active cox treated first and then come back. But then she didn't go back, and she came 6 months later to me. So she had like an ulcerated
mm.
wound, very young
Oh, wow.
23-year-old girl. So, but unfortunately, we had to do a mastectomy with the underlying muscle as well. But we did put an LD expander, and I think 3 weeks back we changed the expander to implant. So very few cases, probably we would do that.
Wow.
Yeah.
I mean that makes sense with
Interesting. Yeah.
the TEs and the implant-based reconstruction. I think you do worry about infection more, correct? With
Yeah,
the compared to
particularly for
autologous.
people that are
Yeah.
traveling and
Yeah.
they're going somewhere. And to be
Yeah.
honest, we see the same thing here.
Yeah.
We're in Ohio, and there's a lot of rural communities in Ohio,
Yeah.
and sometimes you don't quite know where patients are going to be for further follow up. And so, particularly for those patients, I think we see ourselves doing more deep flaps also.
And do you have patients coming back to you? What is the motivation of your patients? When I was working in Europe, I saw patients coming back for their second, third surgery for contracture release, for a little lipofill here or there. But I don't see that in India. They're like, as long as overclothes and in
Hmm.
bra symmetry is there, they're happy with that. So that is another reason that, with implant, I don't know if they're going to come back for corrective
Yeah.
Mm.
procedures later on.
Yeah, it's a tough one. Nobody wants more surgery. So I think for everybody, it's
Yeah.
difficult to come back for something else. We try to set up that expectation that there's, a strong likelihood that they'll need one more step. I will say that in America, there's a federal law, which is great, that has insurance companies pay for that symmetry operation. I think that changes people's motivations a little bit also because it's less of a financial burden.
So what percentage would you say you do deep versus the implant-based reconstruction?
We're 50-50.
Oh,
Like
wow.
we've looked at our data and we are right down the middle 50-50. And it tends to be obviously patients that are a little bit older, that have more in the abdominal area. So in general, patients over 40 tend more towards deep flaps. Younger patients, we tend to do more implants. Maybe
Mhm.
they haven't had children yet. Certainly someone who will be radiated, we're thinking about deep flaps. We do a lot of delayed immediate reconstruction. So I feel like we have a fair amount of neoadjuvant chemotherapy. And so those patients will oftentimes put a tissue expander in and then bring them back for a delayed deep flap. But yeah, our numbers are right down the middle, 50-50.
Yeah, so we were just talking about how, I mean, our incidence of breast cancer is going up in younger women, but even when the guidelines don't even come into play. So it has really been more of self breast exams, clinician exams is how women are getting diagnosed. And I think you are doing incredible work in educating people on a breast exam. I think that's where we need to start as young as age 20. As soon as women start getting breast, I think they need to be aware of it. And it's such a taboo, right? Like people don't want to talk about breast. Families don't talk about it. But I think it's what you're doing with your educational platform. I think hopefully that's going to change.
I hope so too. And that's the idea. I think even for you, both of you, that you know what you do with your podcast and your channel is to bring about awareness, and not just to patients who are to patients or to survivors, but even to people around them who are
Yeah,
not patients. You know, the general population who need to know that no one is really immune to breast cancer. Doesn't matter what risk factors you've
yeah,
had or not had, you're male or female, anyone can
yeah,
get breast cancer.
yeah,
And you know, sometimes when we have these talks to general population, we see men get up and say, oh, okay, this is breast cancer awareness, and about to make a move. And I tell them, no, you need to sit down, you need to hear about this, not just as someone who can potentially get breast cancer, but as someone who needs to go back home and talk to his wife or to his daughter or to his sister and tell them that, you know what, breast cancer is a thing, or the numbers are increasing. Either like you check yourself or go to a doctor and have a general examination. You know, that's that kind of awareness and that kind of openness really needs to come in.
yeah. I just diagnosed a male just past week, and he's coming back next week to
Mhm.
have a discussion. But in America, we see about 2,500 men will get diagnosed with breast cancer, and unfortunately, they also have get diagnosed a little bit later stages compared to women.
Mhm.
And so, their prognosis may be a little worse just because they are being diagnosed a little bit higher stage than women.
You
So,
know, one thing I want to add, this is just something I've been thinking about, and you two are experts, so you may have some opinions about this. One thing that we're seeing in America is a proliferation of these testosterone clinics.
mm,
So there's now literally one on almost every corner, it seems like. And of course, testosterone is metabolized into estrogen at some level.
yeah.
And do you think that that plays any role here in a male breast cancer population, specifically testosterone treatment, and how that will then lead to,
Mhm,
at some level, increased estrogen levels with aromatization?
mhm. I just don't know in the United States if we have enough data to
Mm,
say that it can lead to, increased breast cancer rates. In women, I'm not opposed to using like vaginal estrogen or DHEA for, symptoms when women take endocrine therapy. But I don't think we really have concrete data to say
sure.
that.
Yeah.
Yeah. Do you agree?
I think I would. And same, you know, of course, when we give long-term hormonal therapy, and even we deal with a lot of women who are menopausal. So to deal with their symptoms, we go through ABC, but never really opposed to, you know, first moving from lubricants to, you know, local estrogen, vaginal estrogen tablets or gels. You know, that's completely fine.
Right.
What do you tell patients who've had a breast cancer about hormone replacement as they get older?
As they get older, you know what, hormone replacement therapy is not very common in India. To tell you the truth, even when we have a menopausal patient, I mean, all patients, we take a very detailed obstetric and menstrual history, and a part of that is hormone replacement therapy. And can't remember the last time someone told me that they've taken hormone replacement therapy. It's very very rare. So generally for most patients, I think we'd like them to come back to us and tell us what are the menopausal symptoms they are facing. Is it hot flushes? Is it vaginal dryness? So it depends on what symptom of menopause we are dealing with, and based on that we will go stepwise. As I said, for probably vaginal dryness or dyspareunia, we'd probably start with giving just a regular lubricant, and then probably move on to estrogen tablets. And then for hot flashes, we'd also give them some other options, or even use some SSRIs before moving on to hormone replacement therapy. And that would be, you know, shortest duration, lowest dose, and we'd get a gynec involved and take it from there as a team.
Yeah, I 100%
But
agree.
as yeah.
Yeah, I 100% agree. There is this huge movement going on in the United States for women to get started on hormone replacement therapy, and how doctors don't talk to women who are going through menopause. Now, obviously there's women who have not had breast cancer. There's women who've had breast cancer. And I tell people I've had breast cancer and premenopausal, but when I do go through menopause, I don't think I'm going to take hormone replacement therapy. I just don't think we have enough data to say that it's not going to increase recurrence in women who've had breast cancer. Now, for women who've not had breast cancer, the studies have shown hormone replacement therapy combination of estrogen progesterone increases risk of breast cancer by 20%. And so, if you take it for over 5 years, and short term use is okay. But like we talk about symptom management. So, hot flashes, you can use magnesium, vitamin E, Neurontin, SSRIs, FXR, things like that. And there's also non-hormonal medication now that's Veoza, that we use for women who had breast cancer, and it's non-hormonal and works really pretty good. Has some side effects. It's a little expensive. And so again, like for vaginal dryness, things like that, we start with moisturizers and lubricants, and then they can have like vaginal estrogen, things like that. So I think it's a lot of communication that women need to have with their providers, with their doctors, and there is ways to fix it. It just takes a lot of talking and shared decision making.
So that's interesting. That's not a statistic I was aware of. In women who have not had a history of breast cancer, who are on HRT, it increases their risk
By
by
20%
20%
if
after
you're
five
on it
years.
for more than 5 years.
Oh, I did not know that at all.
Yeah, that's
Uh,
American Cancer Society.
and even 1 year use of hormone replacement therapy increases your breast density, and 2 years use of hormone replacement therapy increases your risk of mortality from breast cancer, should you get it in the future.
Mm.
So I mean, I think we need to be very, very cautious when we give hormone replacement therapy, and use it judiciously and talk to the patients about the risks.
Yeah, no, 100%. Thank you for that, because I do have a lot of women come in and asking for hormone replacement therapy. And, there is a place and time for everything, but I deal specifically with women who've had breast cancer. So let's talk about your symptoms. What can we do? And I'm a big proponent of quality of life myself. And so therefore the podcast. So I talk about, hot flashes, how to deal with it, fear of recurrence, sexual wellness, and, just different things that women go through as they're diagnosed with cancer. And of course there's the collateral damage that comes with chemotherapy, radiation, and endocrine therapy. And so just kind of talking about each one of those things and how we can help women. And it takes a lot of time, but I think it's important that women be advocate for themselves and talk to the providers. And I'm just curious, in America, the hormone receptor positive breast cancer, we say about 65% of the women are diagnosed with that. And then there is, small proportion, about 15% triple negative. And then there's in between is like HER2 new positive cancer. How about that in India?
So in India, we see a little more on the triple negative side. Of course, hormone receptor positive is still the most common, but we see about 30% triple negative breast cancers and about 10 to 15% HER2 new positives. So that's the general data. But also, I think we do need to take into account the fact that we see a lot of younger women developing breast cancer in India as well. It could be just that we're a younger population rather than the proportion of people getting breast cancer at a younger age. But we do know that younger patients are more likely to have triple negative cancers, more likely to be associated with genetic mutations and things like that. So I, related or not, we do see more triple negatives, about 30%.
Yeah. I think the biology may be a little bit different too in the Indian population. And I'm actually definitely seeing that here. The biology of breast cancer is a little bit different than, like the Caucasians and other ethnicities. So,
What do you see?
so in the Indian Americans, I'm seeing more triple negatives than the HER2 positive breast cancer, not as much hormone receptor positive breast cancer. So,
I mean, it's interesting. You would imagine that because there historically there have been Gujarati and Punjabi, waves of immigration. And
yeah.
so there's a little bit of a founder effect
Hmm.
of, those groups have been in America. And so you would imagine that there would be differences just based on the immigration patterns.
Yeah, so once you're migrated to the United States, came at age 16, so your risk is pretty similar to the risk of someone in the United States. So 1 in 8 women, so our risk is 1 in 8 once you've lived here, because you're getting acclimated to the environment, to the food, to the stress level, and all those things. So and the sedentary lifestyle, unfortunately, that plays a huge role. In India, people walk everywhere and things like that. Here, everyone like goes in cars and not being very active.
No, I wish people walked more in India. I that
Yeah.
too. Uh, I don't know if people, they don't take. Probably, what I find is most of my patients or even people around me don't take out the time uh, for health. So if they have to walk somewhere, yes, they will walk it, but they won't do that half an hour of walking just towards their health, to become healthier, to reduce their risk of all these diseases related with obesity and sedentary lifestyles. So, and yeah, even in India, there is not that much walking, I would say.
Yeah, yeah. I know, people have helpers, right, that come and help. I know my mother's in-laws families, they have helpers who come and, do the laundry or wash the dishes, or someone comes and cooks. And I'm like, so then what do you guys do then? So I'm kind of jealous, I think. That's all. um,
We manage them, which is a joke.
right. No, I'm sure it is. Yeah. And I kind of want to briefly touch on two things. One is new adjuvant chemotherapy for our audience, as the chemotherapy women or men receive before surgery. How often do see that with your patients, that they get chemotherapy before surgery?
A fair bit. So I think even maybe in the last 5 years, the indications for giving chemotherapy itself has increased in triple negatives and HER2 positive, especially. We are giving more neoadjuvant chemotherapy. Um, but yes, I would say it's almost 60-40, I think, a lot, or maybe just about 50-50. So of course, anyone who's probably node positive and slightly larger triple negatives, maybe even 2-3 centimeters, and HER2 positives, they get neoadjuvant chemotherapy first, because we know that it really has a dramatic effect. And especially with all of these dual blockades and immunotherapy coming in for triple negatives, we are seeing a lot of response with neoadjuvant chemotherapy. Therefore, smaller resections, I think it makes a big difference as well.
Yeah.
Able to conserve axilla, able to conserve breast. So I think in the recent times, the numbers have increased, and I would say it's about 50-50, or maybe even a slightly more, we are giving neoadjuvant chemotherapies, a little more than 50%.
Yeah, yeah. So same here for triple negatives. It's more than a 2 centimeter tumor or lymph node positive disease. They get neoadjuvant chemotherapy along with Keytruda now,
Mm.
pembrolizumab. And then for the HER2 neopositives, they also get neoadjuvant or chemotherapy before surgery if they are 2 centimeters or lymph node positive, not just with chemotherapy, but the dual targeted therapy, Herceptin, Perjeta are the two drugs. And
I feel like this has been a big change versus maybe 10 years ago, where I did not see as much neoadjuvant
mm,
chemotherapy back then.
you mean in India or
No,
here?
here,
Oh,
yeah.
here.
Yeah.
Yes, this definitely has been, we've had like so many newer drugs, Keytruda or pembrolizumab for the triple negatives. Pertuzumab, I was in training 10 years ago. That was just barely coming out. So for women who had HER2 positive disease, they only had option of Herceptin. Now we have, Pertuzumab
Hmm.
or Perjeta and, many other HER2 targeted therapies. So we are making great strides and, trials that, women are enrolling and, open to enrolling, and we have more data on these medications, which has been great because that amounts to better survival for these women and men. So,
And it's quite interesting actually, because in India, most of it is not covered by, many people don't have that kind of insurance. So a lot of it's pay out of pocket, and none of this pertuzumab or anything, it's very expensive. But I mean, people are still doing it and they're able to take it. So not everyone gets it, but I think 50% of HER2 positives uh, will definitely get the dual blockade, and the rest will at least get trastuzumab, because we also have quite a few biosimilars coming in. So some patients who are not really able to pay for the Herceptin will get some of the biosimilars.
Yeah, I think the cost piece is a whole different
yeah, I
part
know.
of this. I think
Yeah.
that the rural urban divide that you mentioned, we certainly do see that same type of problem here. I mean, even though America has health insurance, it's certainly not a national health insurance, and there is definitely a divide. I think we see it
Yeah.
in our practices. I certainly see it, the reconstructive surgery side when it comes to insured versus not insured. So I think that's a worldwide problem.
Yeah.
Yes, coming back, even when we were talking about DEPs and implants, um, I mean, the cost is at least 3 times to have a DEP flap. If even including the implant and the cost of implant, it's still DEP. The longer stay, the longer surgery hours, two surgeons involved, all of that, it really brings up the cost to 3 times.
Do people opt for like just a flat closure, like the aesthetic flat closure without
Yes,
any
often enough,
reconstruction?
often
Yeah,
enough,
yeah,
often enough.
yeah,
So, especially in women in whom we are removing skin as well, I see a lot of them would rather just have a flat closure and do a prosthesis. So, we do give, a knitted knocker to all of our patients who have
yeah,
mastectomy when they're going home, and with the option of silicone prosthesis a little bit later on.
yeah, yeah. That's interesting. We have knitted knockers too here. I didn't realize that was a worldwide thing, but
I don't
yeah.
know what that is.
It's
What is
not.
it?
So we have the Indian version of it. So we have NGOs here.
Okay.
Um, yeah. So
So knitted
we
knockers is like breast prosthesis. Like these
Okay.
women like knit them
I've
and
seen them around.
okay.
Yeah, I've
Yes,
seen
yes,
them. I
yeah,
didn't know
yeah.
they had a name called knitted
Yeah.
knockers.
Yeah, that's on my list of things to do is learn how to make a knitted knocker. But when I'm have a free day, which is not very often these days. Dr. Karishma, I have another question, and I think we're going to probably let you go, and it's getting late for you. Do women and men offer genetic testing? Is that something you talk to women about to test the genetic, like to see if they have a mutation?
definitely. So all men definitely do have genetic counseling and testing. And for women, we go back to what we've been learning, all bilateral cancers, patients, younger women with breast cancer less than 40, all, triple negatives, even to a slightly older age, up to 50, family history of breast, ovarian, prostate, colon cancers, all of that we take into account. So, as I said, our history taking process is very long. So, family history does come in. And so these are some of the things we look at. Definitely, we make sure that our patient goes to a genetic counselor, because I don't think it can be emphasized enough how much a pretest counseling, how important that is. And so definitely pretest counseling and the full pedigree mapping before they go in for genetic testing. So I'm very pro that genetic testing is important. What I'm not pro is a lot of, unfortunately, companies coming in and advertising whole genome sequencing
Oh yeah,
just everybody and anybody, with no counseling, with no understanding of what it is, that
yeah.
something might get picked up and you may need to do something. And we have patients coming up with so many VUSs, which is variants of uncertain significance, and patients don't know what to
What
do
that
with
is?
it. We
Yeah,
don't know what to tell them. We just tell them that every time there is an update, maybe we circle back to this. So so
yeah.
that, but yes, definitely all younger patients, triple negatives, male patients, bilateral breast cancers, patients with family history, um, those are definitely patients who go in for genetic counseling and testing.
I'm curious if the percentages of what we see, BRCA, CHEK2, PALB2, if those percentages
Yeah.
are similar to the Indian population.
I did read some place where the BRCA is they're identifying more BRCA mutation in Indian women. Is that correct?
I've read that also.
Yeah.
Yeah, well, so there's actually a lot of data that, and most of it actually comes from Tata Hospital, because they've had genetic testing. They have been doing their own genetic testing, and the the cancer genetics clinic that they have there has been there for more than 15 years or more. So there's a lot of data that comes in, and within the Indian population they have also identified subgroups in which you see specific types of mutations. So lots of work is happening. And yeah, so I think most of the mutations that we see are BRCA1s and 2s, very few and far between PALB2s, RAD51, all of that. And of course P53 also, but that's more towards phyllodes and sarcomas and things like that. But yeah, we do see a fair few BRCA1 twos. And when we talk about treatment for them, it's a little bit divided, because again we don't have guidelines for this, but we do offer surveillance to all women with MRIs, with annual MRIs and mammograms. MRI starting earlier than mammograms. And bilateral ovarian oophorectomies between 35 to 40 to all BRCA1s, and maybe just after 40 for all BRCA2s. And for prophylactic mastectomy, actually we have a bit of a divide. So we do talk about it, but we don't strongly recommend it. So we do tell them it's an option. And a fair few women start with surveillance, but after 5 years of surveillance, or even 3 years of surveillance, they're like, is it just better that, the anxiety that comes with it, the stress that comes with it, and just doing that test in that claustrophobic machine.
Yeah.
Some of them switch over after a few years of surveillance
Yeah.
and
Yeah.
chemoprevention, of course, with tamoxifen.
Right, right. So yeah, I mean, we have the same exact guidelines here for like high risk screening with the mammography and MRI, alternating those every year. And we talk about chemo prevention. Not too many women are compliant, because of the side effects of the chemo prevention. I do say that we do offer, or women opt for a prophylactic mastectomies most of the time with reconstruction. And in our own program, we did a study which talks about cost analysis. There's a better improvement in cost if you actually offer surgery while you're younger as opposed to getting surveillance every year. Not just the
Mhm.
surveillance, but then if they find something abnormal, there's biopsies, and the anxiety that goes with the biopsies just impacts the quality of life. So we don't want to take too much of your time, but you're doing such great work, and in social media and work. And we just before you're done here, we want to know what your day is like, in the day of Dr. Karishma Kirti. What's your day like?
So a day in my life. So of course, I think my 6-year-old made a present some time back. So it starts with her, and she goes off to school at around 8 in the morning, and then it's me get ready and out of the door by 8:30, and 9 my day begins. So I think 3 days a week I have surgeries, and I'm also a lecturer or an assistant professor at a medical college. So
Hmm.
twice a week I go there, and my first half is spent there, and the second half is mostly in OPDs. On those days, if I have something like an emergency or someone needs a port, needs to start chemo, that kind of a surgery, a small or something, can happen on those days. But the main surgical days are thrice a day. So morning surgery, evening OPD around 4 to 6. Back home, hopefully by around this time, around 5:30 or 6, and back here with my daughter, and then some family time, and then she is off to bed by 8 or 8:30, and then some time for myself. So catch up. Even data entry is such a big
Yeah. Oh, so you have the
job.
same
So some
electronic
of the
medical records as what you guys use also?
We do have electronic medical records, but unfortunately, none of them can be translated onto an Excel sheet or a worksheet. So then the burden falls on me or one of my lovely residents to then transfer all of that data and enter it doubly into the worksheet.
Oh, wow.
So then that,
I
and
think
then
some things are also universal. Breast surgeons are very busy.
Yeah. So are the plastic surgeons. We keep them
yeah,
busy.
yeah. But and I missed my workout. I do work out, and that's why I always tell my patients that you also
Yeah.
need to work out.
Yeah.
If I can find time, you can find time.
Are you a
So
morning workout person or an evening workout person?
evening workout person. So usually, as I said, 5:30 or so. So 5:30 to 6:30, and then 6:30 to 8. That's around the time my daughter comes home as well from her playing and everything. And then we all have dinner fairly early, 6:30 or 7. And then yeah,
She's a very early morning workout person,
Yes.
I know.
Yeah.
yeah.
So I like on the weekends, I get up really early. I go for a run in the mornings before I go to work. And weekdays, I get up around between 4:30 to 5 and work out, do something in the house. We have a little gym in the house. And then before going to work, it just sets a good tone for me during the day when I work out and think about the patients I'm operating on. I operate 2 to 3 days a week as well and see patients the other 2 days. But I'm also the associate program director for the breast fellowship. So I train a breast fellow, and we have residents and medical students. So that's busy. I do love that part of my job in addition to taking care of patients. But you probably have seen me post on social media. Anytime I go, I'm doing workouts or taking time with my family, things like that. I post it just to kind of, motivate other people to do the same and take time for yourself in your busy schedule. I think that's so important. And for us women, in especially the Indian women, I think we are so busy taking care of everybody else, don't take care of ourselves. And we need to change that dialogue and taking care of ourselves so other people watch us, and particularly your daughter and my daughter, and then they take care of themselves and not consider that to be selfish. It's actually selfless, to be honest.
Yeah, I think
So
it's very inspiring. I mean, you're both
yeah,
very busy
yeah,
and to take the time to take care of yourself, it's important because it's not only
Mhm.
important for you, it's important for your patients, your colleagues.
yeah.
So
Yeah, this has
kudos.
been so, yeah, this has been such a great, talking to you, such a great time talking to you. Thank you for, sharing. And, I'm just really very amazed at all the things that you offer to your patients. It's very similar. I mean, we
You guys
do,
are kindred spirits.
yeah, yeah. I mean, I'll take that because she's so beautiful.
No,
So
I'll tell you
yeah,
one thing that, my experience in Mumbai is not the same as experience of a lot of surgeons working through all of India, because the resources that we have here, the kind of patients that we have here are so different from someone in my hometown even. So, that's it's so different,
yeah,
and that's why maybe we're closer to each other than if you spoke to someone from a tier 3 city.
yeah,
uh,
yeah,
we're just about and that's what I tell my residents as well, is that learn your mastectomy first, because a well done mastectomy is a lot better than a poorly done breast conservation.
yeah,
uh, and that's the first step. And if we get even that from our patients who are traveling to us to see us after they've had surgery, I mean, I would be very, very happy to see a
yeah.
well done mastectomy rather than you know
Poorly done breast
Yeah,
lumpectomies.
that's a
Yeah.
great point.
Yeah, that's a really great point. They're all very lucky to have you, your
Mhm.
patients as well as your residents and your, all these I don't know, do you train medical students as well? I take it, right? Yeah.
Yes, yes. So we
Yeah.
have residents, we have Masters of Surgery residents, and we have DNB, that's a national board. They also have residents. So we have them in both institutes. So
I see. Yeah. Well, thank you so much for taking the time. Thank you, everyone, for tuning into the Breast Cancer Podcast. Remember, you're not alone in this fight. I encourage you to be an active part of this podcast. Please share your stories, questions, and suggestions for future topics at my website called drdeepahalaharvi.com. And please share this podcast with others, especially if you found it useful. And please also give it a 5-star rating, if you will. Stay connected as we navigate the complexities of breast cancer. Until next time, take care and keep shining brightly. Disclaimer: this podcast is not intended for complete medical advice.